Hello, Connecticut, and welcome to the Paid Leave Podcast. The title basically says it all. I'm Nancy Barrow, and I will be delving into this new state program and how it can help you and your family. This podcast will give you information you should know about Connecticut paid leave and maybe just a little bit more. Connecticut paid leave brings peace of mind to your home, family, and workplace. Welcome to the Paid Leave Podcast. The National Burn Awareness Week is in February, and it's recognized by the American Burn Association, also known as the ABA. It's a chance to promote burn prevention and awareness in communities. And this year's theme focuses on reducing burn risks in homes, apartments, and all living spaces. My guest today is Dr. Roselle Crombie, who is a surgeon specializing in general surgery, burn surgery, and surgical critical care at several of the Yale New Haven Health System flagships hospitals in Southern Connecticut. That includes the Bridgeport Burn Center. Her particular passion is a mix of burns, burn trauma reconstruction, and wounds and general surgery. She is highly involved as faculty in the Department of Surgery, the Yale School of Medicine, over the course of her career and mentors the younger pre-health generation. Her postgraduate fellowships were in burn surgery and surgical critical care at Yale University School of Medicine, where she currently remains on faculty. Outside of her job nationally, she has served as the 32nd president of the North American Burn Society and served on the Ethics Committee and Epidemiology for the American Burn Association. She is a fellow of the American College of Surgeons, a fellow of the American Burn Association. She was recently appointed to be the director-at-large for the board of the American Board of Wound Medicine and Surgery, and is currently the VP Program Chair for the Connecticut American College of Surgeons chapter, the executive board, and chair of the Women's Surgery Group, and is involved in the women's surgeon groups within several national societies. She serves as a reviewer for the Journal of Burn Care and Research, the Journal of Wound Care, and has served on the Military Review for Burn Grants. She's a member of the Consensus Committee on Tissue Regeneration for the Journal of Wound Care. With a team of other burn colleagues, she sits as VP of the non-for-profit Reach Burn Foundation to support the needs of adult burn survivors. Additionally, she serves on the board of the Burn Research Foundation. She has numerous publications, and finally, Dr. Crombie is married with 3 children. Welcome to the Paid Leave Podcast, Dr. Crombie. You are a busy woman.
Thank you. Yeah, I think we all try to do our part. It takes a team, right?
It sure does. We'll start at the beginning. Can you tell me about your involvement with the American Burn Association, also known as the ABA?
Yeah. So, the ABA is kind of like our overarching body that oversees a lot of the burn surgeons and burn care throughout the United States. It first started in 1967, really just kind of grassroots. I think it was like 17 surgeons had been meeting for a period of 6 years. And then they kind of decided, hey, we have a unique specialty. We've learned a lot after the war. Why don't we actually form an association? So 4 of those individuals, including a bunch of different positions, there's Basil Pruitt was he's like a pillar in burn care, and a Dr. McMillan, Dr. Arts, Dr. Feller, and Dr. Boswick formed the actual ABA in 1967. All those guys have all been presidents of our association, and since then it's grown to thousands of members now that include the burn team. I'm really just one small part of the burn team. I can't take away from my nurses, my therapists, the social workers, the firefighters that get the patients to us, and the EMTs, and certainly all of the other staff that support us to create this burn environment and the continuum of burn care even beyond the hospital. And that's really what the ABA formed this incredible team of just individuals that are part of the care. And I wish every disease had something like that.
Yeah,
it's essential to the burn patient because there's so many other issues that they need to deal with. Yeah, that's how it all started.
And how does it affect Connecticut? How does the American Burn Association, are you a member of it? And what are their responsibilities for that?
I at first became a member when I was a fellow, and that was really my first exposure to this community. It's a very unique specialty in that it crosses, for physicians, it crosses both general surgery, plastic surgery. I know some colleagues of mine that are in rehab medicine. And it's really a home for all of those individuals. So you could really just be a member and come to the conferences, which there are many now. There's our one conference that happens throughout the, usually in the early spring of the year, but there's regional conferences, like we're in the Northeast. There's a Southern Burn colloquium, and then they're just reenacting Western Burn. There's a Midwest, there's Ohio. Mm-hmm. So in addition to overseeing and kind of helping all of those different areas, it really is a resource for us to kind of talk about protocols, what's being done, because there's only at the actual moment about 250 burn surgeons in the nation that are caring for all of these patients. I mean, we have teams, we've got, mid-level providers, nurse practitioners and PAs and stuff like that. So it's essential that we have an overarching body that can kind of guide us. And so the way that it kind of helps us is to really help with things such as training in something called ABLS, so advanced burn care. And that can be, many people can take that, even EMTs. You don't need to be a physician. And certainly they do things such as lobby for us. I remember as a fellow going to DC, being dragged down there. And that was my first experience of like meeting our senator at the time and really advocating for the different things that we were having in Connecticut related to our burn patients. And so they are involved both in advocacy, prevention. I was involved in publishing on treadmill injuries because people would be getting back in shape, and then a lot of these kids would just grab the treadmill and then get a full thickness friction burn. So we were able to, lobby and change through a lot of publications and stuff like that, to change the safety. I don't know if you notice, if you go and look at, a treadmill at Dick's Sporting Goods now, it has a like a safety latch to it that will immediately shut off if you were to fall off of it, or there's different safety things. And that's all part of the lobbying and different research that we kind of brought to our nation. So the ABA is very involved in, a lot of things, education, prevention, but also care.
It's amazing. I know that you work at the Bridgeport Burn Center, and it's the only burn center in Connecticut. But you said there's only like 250 burn surgeons. So do a lot of people from out of state come to Connecticut to the Bridgeport Burn Center?
Yeah, so we draw from the other burn centers in our area. There's Cornell, which is down in the city, Rhode Island, which is in Providence. And then we do send, there's the Shriners, which is a wonderful institution, kind of obviously very well funded. And most of our larger burn kids we send up there because the way that I think about it is if my kid had a terrible, devastating burn, there's a school in the hospital. We just don't have that at our burn center here. But it's kind of cool because we have a network of burn centers, but we draw from Southern Rhode Island. We'll get patients from there. Western Massachusetts, we get a lot of patients from because both their burn centers are in Boston. So as you can imagine, if you think of just like the northern part of Connecticut, as you go up I-91, like all of that, it's much quicker for them to come down. I remember getting a burn from Vermont, Southern Vermont, one of the years that I was here. And we do get some, New Yorkers as well, depending on where they are, because the Connecticut state line is on the border there.
How did you get interested in helping burn patients? Because I think it takes a very special kind of person to do this work. It's a lot. There's a lot of disfigurement. It must be really hard or rewarding when you can help patients.
I never think of the hard part. So my personal story is that way back when it was a required rotation for my training. So you had to have burn surgery as a rotation. And that was really my first exposure. I was shocked and pleasantly surprised that it combined a lot of different things that I liked. So in that 6-week period, I had a lot of inspirational patients. So I think that that's what really drew me to it. And then I sought to pursue an extra year of that training. And, to just tie it back to the ABA, I didn't realize that it was going to be such a collaborative community, which is wonderful. And I think in medicine, there's so much competition. It was very different than some of the other specialties that I had experienced. Like it was really neat to meet people that were ahead of me in their career. It was so collaborative. And I think that we have to be that way within burns because there's so few of us.
Yeah.
So all of those things are what really kind of brought me into the field. And kind of like you, it's like when we choose our career and we figure out what are the things that we like, it kind of comes just naturally.
What are the most common types of burns that you see? Do you see home, kitchen, splatter burns, or is it work, or are they all over the place, electrical, chemical?
Yeah, so we see all of them. Just percentage wise, the vast majority of burns are scalds. Unfortunately, there's a more of a male predilection in sort of the younger age group as well. Unfortunately, it's a lot like this. There's seasonalities to burns. So right now we're in the wintertime, and we see a lot of kids with scald injuries. So they're pulling down, like toddlers that pull down the tea because it's up on top there, water bottles or some of that stuff. So those are, or they put the baby in the sink and the baby like kicked the faucet and hot water came down on them, and a lot of our prevention is focused around that for, an overwhelmed parent or whatever. There's house fires, obviously, at this time of year as well.
Chimneys,
With the advent of the fire pits, that happens to, a lot more in sort of like the fall and the spring season, celebrating, maybe not paying attention to different things. We've had people literally fall into fire pits. That's a whole big thing. And then certainly the other sort of recreational thing that we see a lot of, fireworks. There's always like a little bit of something going on with that, or people will barbecue on the beach. We've got beaches down in Southern Connecticut, and they'll forget to bury the poles, and you're walking, barefoot on the beach as people do, and you get burned. So yeah, we see all of them, in terms of those are the most common, but we definitely have, like I've had chemical burns from the various universities around us. I've had somebody put too much chlorine in the pool and the poor kid got shocked.
Wow.
Yeah. We've got, electrical workers that are up there trimming bushes and, they forget the concept of physics and the electrical field and they get zapped. So there's all sorts of different mechanisms that we see, but statistically the most common are really the open flame, and the scald is the most common, followed by open flame. And
how do you treat them differently? And maybe you should tell me what the difference is between like first degree and fourth degree burns.
Yeah, first degree burn is, everybody sadly is very familiar. It's sunburn. So it is injury to your top layer of your skin called your epidermis. And it's usually very painful, as you can imagine, because all the nerves are intact. Second degree burn is really the best way to describe that is if you see blistering. So it's gone through the first layer, the epidermis, and then into the second layer of the dermis, and your body is reacting by, putting fluid into that area, and that's really, nerves are still intact, and there's also a superficial second degree and deeper second degree, which is closer to third degree. Third degree means that you really, you've gone all through the layers of the skin and kind of setting into a pretty deep layer. And those by appearance tend to be really thick and kind of not sensate, and they don't move as much as you can imagine. The way that I akin it to is like when you fry an egg, you can't get it back to that liquid stage. It's just solid. And then fourth degree burn is beyond that, down into sort of the deeper tissues like the bones and the muscles and stuff like that. And we really see those more in sort of more the devastating industrial injuries, or if there's a house fire and the patient's been found down for a long time, car fires and stuff like that.
And tell me what you do as a surgeon and how you treat people.
Just like any other surgical disease, we always have to ask ourselves, do they need surgery to begin with, right? Are we going to make the patient better that way? Specifically for burns, they can be incredibly painful, as you can imagine, if every single part of our skin has nerves, right? So to treat the skin, you have to take out the devitalized tissue. That's not something most people will tolerate. If you can imagine, like a very painful sunburn, and even some very fair individuals, like I have my husband's redheaded, if he blisters, it's very painful. So that's something that you have to take them to the operating room for, primarily for anesthesia. But the goal is really a concept called debridement, where you take away the dead tissue to allow the living tissue to heal. And then eventually, if you need some of it heals on its own. Some of it we need to replace with its own skin. And that's what a skin graft is. It's like planting sod. We take a little piece from somewhere else in the body where there's normal skin, and we put it into the area after it's been debrided that's thickly burned. But there's also other things such as down the line, people have scars. So one of my big interests is to do a lot of different reconstructions to, loosen up that scar, make it more functional. And then some of that includes lasers. There's quite a bit that we do as a surgeon for those treatments.
Yeah, and I know that you mentioned a team. So tell me how that works too. So if a burn patient comes to you.
So the team includes first the outside hospitals where they're being seen or clinics. And that's incredibly important. We do a lot of outreach. We have this great guy, former burn nurse named Jay Bresky, who goes out and does a lot of education to the various different, not only ERs, but just urgent cares, because a lot of people are seeking care there, just what should be referred and what shouldn't be referred, but also how you can, dress a burn, all that other stuff. But we really teach them how to evaluate it. So just like you asked me, what's the first, second, and third degree burn? Like, it's very important if I can't see the pictures for them to be able to describe that. So there's education of that. So that's the beginning of the team. And then there's the transport team, which includes obviously the EMTs, the pilots or the ambulance drivers, paramedics that get the patient safely from wherever they're going to our hospital. And then there is the on-site team, which always includes the nurses, the burn surgeon. There's typically a burn tech who is medically trained to help us with, dressings and stuff like that. And then literally every week, we kind of map out for the family and for the patient what happens. Once a week, we meet with the whole team. So the doctors, the nurses, the physical therapists, the occupational therapists that really deal with kind of just face and hands, nutritionists, there's social workers to kind of help with the overall planning on how we're going to get them through the hospital stay and how we get them home, what support do they need. And then there is clergy, and we have different types of counseling services that happen as well. So that team sits down pretty faithfully every week on Tuesday at 10 a.m. to go through every patient that has been admitted to the burn center to kind of come up with a comprehensive plan. And I find it great because two things. I always learn something from listening. And I think it allows us to come up with a more comprehensive plan for the patient. But then additionally, I think it's incredibly important for each one of those individuals that are sitting at the table to know that they have an important role in this patient's care that we can't do, without them. So it's a chance for them to speak. And it really kind of helps to really just make it a wholesome team effort to get this patient through their care. We also have an outpatient, after they go home, they come and see our PA and then us. I have a burn fellow. They're there, residents, obviously, because I'm faculty at Yale, they're rotating as well. And we see that they're part of their care, both in the inpatient and the outpatient. And it's nice because it's a continuum for them to be seen, as outpatient care as well. Because a lot of, I guess I should say that we've been really great nationwide about doing things about prevention and getting them numbers, I think, down to a much better level than, when I first started this over 20 years ago. But what that means is that we're managing a lot more of those patients as outpatients. So we've created effectively the same team in the outpatient setting to help them through the next phases of their recovery, probably the most important phase, quite frankly.
Yeah. It's interesting that you said the educational part of it, that you've educated enough people so that with prevention, so that the numbers have really decreased in the last 20 years.
Yeah, it's still a big problem, but it's certainly,
yeah.
And like I was alluding to at the beginning of the podcast, there's been a lot of safety things that, that happen, over time in terms of building in, like I bring up the fireplaces, like a lot of places in the nation, they don't have centralized heating. They have like a stove with a glass stove. So we were getting like a bunch of people and toddlers just going up to the glass. So there's been a lot of changes in the design of both fireplaces and glass stoves. To be a little bit more, to be safer.
Yeah, and that's your advocacy right there, with the ABA going and advocating for those burn patients. I know that you mentioned counseling, and tell me about the mental health and behavioral health. How important is that for recovery in patients who have severe burns?
It's incredibly important. It's probably one of the most important things after you kind of get them through the burn. A lot of our patients, there is a percentage of patients that come with mental illness. So we have to address that and keep their therapies going throughout the hospital stay and kind of keep that in mind. In addition to that, no matter whether it's an accidental thing or intentional or something happened, it's a traumatic event. And we really, all of us have been kind of trained in having to help the patient through the trauma. And sometimes we have to get our psychiatric colleagues involved. We certainly have education and counseling, throughout their hospital stay as well. Because in a lot of ways, their lives are forever changed, right? Because they've had something happen. And even if they're able to heal from the initial injury, they have scars, whether they be physical or emotional.
Yeah.
So 100% what I do with my patients is after they get through the hospital stay and they're kind of seeing our PAs and us in the outpatient, is really recommend for actually counseling to happen. And everybody needs a little bit different. Everybody's got a little bit different support system. Some people don't have any. So it's really a matter of, matching the patient with what they need. And then the other thing I should point out is there's a wonderful society that kind of came out of the ABA called the Phoenix Society. And it's a specific society for burn survivors. And they have created something called the SOAR program, where you can actually even have some of my old patients that have gone through it, the SOAR program, become advocates, and we call them in to talk to our current patients, to actually be sort of buddies. And we have a support group, and that's a lot of what, I realized probably early on in my career that we were needing to do more of that for survivors.
Let's talk about the caregivers, because I imagine there's a bit of trauma dealing with a loved one who has been burned. Do you have support groups for them as well?
We do. I mean, a lot of the nurses and the physicians are really great at pointing that out. I think when I first sit down with a family of a big burn in our patient's room, I literally tell them that we're gonna die 1,000 deaths before we come out the other side. And we hope to come out the other side, but there's going to be good days and there's going to be bad days. And that's just the norm, but we're here to help you through it. And the nurses, we've had wonderful, kind of like you were saying that it takes a special person to do burns from the physicians. I think it's even more of a special person to be a burn nurse. And we've been very lucky over the years to have had people that have been here for a long time, or people that come for a period of time in their lives and then they go on to other places, but they're incredibly dedicated. And they are amazing with the families. And I think just bringing them back down and we do this, it's a continuous conversation that we have with the families and the support caregivers, because those are the people that are going to be helping them through the most important phase.
Right.
A lot of my bigger burn patients, they don't remember at all their acute hospital stay. And then all of a sudden they're like, whoa, what happened? Next thing they know, they're going to rehab. So it's really a lot of education in helping the family members or loved ones acclimate to that this trauma has occurred. These are the things that we are concerned about. This is what to expect, and we're very lucky that over time, the survival rate has gotten a lot better, that we can talk about those wonderful, this stage of healing.
Connecticut Paid Leave offers up to 12 weeks of income replacement for mental health issues. You can take your 12 weeks off all at once or in a block that we say. You can do intermittent leave or reduced schedule leave from work. So there is flexibility for the caregiver and for yourself if you're getting treated. So I love the fact that, we can help in this instance with the caregivers and with someone who's going through a really traumatic burn, with getting some financial assistance, right? Like FMLA gives you your job back, but we are the income replacement portion of it. And it's a pretty new program. We've only been around giving benefits since January of 2022. So I think that it would be a really good resource for them to know that Connecticut Paid Leave can help them. And how important are resources like this for you guys to have to talk to your patients and their caregivers?
They're incredibly important. I think, if you think about it, for this part of my practice, these patients never expect to meet me, right? And then all of a sudden their life has changed. And that is the biggest question I have is, when am I going home? When can I go back to my job? When can I go back to school? is another one. There's a lot of, obviously, and it's so amazing that you guys were able to get that program through so that they can have that little breath of, okay, they've got me. It's going to be okay. So, kudos to all of you that were able to push that through, because it's incredibly important. If you can imagine, it's just that safety net of one less thing to worry about amongst the many stressful things that you have to worry about in a burn patient.
Yeah, and I think the other thing is you talked about occupational therapy and physical therapy that happens afterwards, and it's a long process. And if it's a child, like, the parents have to take them, and so they can take that time away from work to drive their child to, occupational therapy or physical therapy, and they can get income replacement. So it just is that flexibility that they can take, small amounts of time to go drive them to their therapies, and I think that is also a really good and beneficial program for burn patients and their caregivers.
You got it. It's super important. So thank you.
Yeah. What can you tell me about burn prevention, since this month kind of highlights the awareness of it? Like, what would you tell parents to do in the home? Because you say it's tea, it's the scaldings, it's the things that are preventable.
Yeah, I mean, it's a lot of the same things that our pediatric colleagues and our trauma colleagues do in terms of prevention of trauma. Like, I think of, if you've got toddlers, I would just crawl down on the floor and see what they see. The outlets are like, every now and then I'll get somebody that got zapped in an outlet because somebody stuck something in there, right? The bath is a very big location for a lot of accidents. And as much as we all love our hot showers, I'm a huge proponent of the actual water being at that proper temperature, because if you can imagine, both for old people and for babies, they have thinner skin than, say, you and I do. So in less than a second with very hot water, they will have a full thickness burn versus, something, that hit you and I. So water temperature is huge. The kitchen is another big place, both not only for scald, but just if you're going to cook, and lots of people have gas flame, don't wear a fluffy sweater or a fluffy shirt. Tie your hair back. Have pot holders, all of these things. We got a lot during COVID. Oh my gosh, we got so many grease burns. I think people were just making French fries left and right.
Comfort food.
Yeah, yes, exactly. So there was a ton of grease burns, wow. And that's a whole nother thing. Grease is worse than water. It actually carries the heat a lot more. So those tend to be really thick burns if you spill the oil. And then the other big thing was to basically, if you've got a grease fire, don't pour water on it, because that's just going to spread it. Just get a cover of a pot, and how do you kill a fire? You suffocate it, cut off its oxygen, it'll go out. So these are the types of things that, it seems like sort of common sense.
Right.
The other thing, when we get to the fall season, we've got a lot of woods in Connecticut. People have a lot of leaves. One of the things, I've had unfortunate patients over the years that wanted to kind of get those leaves to burn, and they do that with an accelerant, and the vapors are also flammable. So, that's a no-go on that. So just, the same bear that taught us all of those things when we were little about
right.
forest fires. It's
Smokey Bear.
It's the same thing. Smokey the Bear. Yep, exactly.
Yeah. Well, how do you refill your coffers? Since, I say it takes a very special person to do this, to be a surgeon and to work on these patients. I do feel that. What do you do to refill your coffers and take care of yourself?
Good question. So I personally like to exercise. So I need to exercise every day. My family knows if they can't talk to me until I've gone and done my thing. But I saw that question. I was thinking to myself, there's a bunch of different things that we do when we've had, and when we've had like a particularly traumatic either day or a patient, who happened to pass away. We always try to take the time to have a debrief, to sit down with the nurses and the team that was involved with them, so that we could, really talk about what are the things, like, what are you feeling? What are the things that we think we could have done better? What are the things that, and I take that time also. I think we're really good at telling people the things they've done wrong, but I'd like people to know the things they've done right. Because I think that's just as important to hear, if not more, to be positive about that. The other thing is we have, because there's so few of us, I think a lot of us are very well connected. I am connected to so many burn surgeons throughout the country through text. Like even in this less than half hour podcast, I can see texts coming from, probably about 25 different burn surgeons on various different issues. So it's like a big group that we can kind of, hey, what do you think about this? Hey, this is going on. What do you think about that? So I think having that collegiality is really helpful. And then certainly the team is huge. Like I don't really get that in a lot of different parts of medicine, and certainly in surgery. But I think that we really depend on each other. So we all just work together, which is really nice.
Yeah, and when you have good outcomes, right? When the people come back to you and you see that they've regained their life back after it must be really rewarding for you.
It is. And I always I see them I worry most about my inpatient nurses because they're not seeing them in the outpatient. Like when you see them across the street in the clinic and you see them like returning to life and enjoying, I always ask them when they get to a certain point, I'm like, do me a favor, go back to me and visit them if it's not going to be too much of a trauma for you, because it would really mean a lot, to those caretakers. And a lot of them do. And it's wonderful to see them kind of regain their lives.
What would you like people to take away from this podcast?
I studied here. I have an MPH myself. So I just really love the fact that you would be able to create the support of the paid leave, because I think it's incredibly important. So I think that's the one thing to know about that, because it's a newer program that started in 2022. And then also obviously a lot of the prevention things that I had spoken about, and just that the Burn Center is a special place that we're a resource for the state, and obviously many other states as well. So don't hesitate to call us if you need us or have a question or need education. We've got a whole team of people doing a lot of different things that can help, so that we can help the burn patient, but also prevent the next patient from being burned. Like I have had a patient that I knew as a 7-year-old that's now in his mid-20s, and I think as a surgeon, that's an unusual sort of longevity relationship that we have, and that individual is now giving back to my current patients, which is kind of cool. So it's a really cool field that has a lot to offer.
Well, I want to thank my guest, Dr. Roselle Crombie, for taking time out of your very busy day to be a guest on the Paid Leave podcast.
All good. And thank you for putting together the program. That's amazing. So
it took a long time for this program to get up and have Governor Ned Lamont make it a law that was passed in 2019. And it really is a rewarding program, as well as how you talk about your program. It's very rewarding knowing that we're helping people.
You are. And I love the fact that you thought about not only just the person that was injured, but really the whole big picture, because we all know that, we have family members that need or caregivers or friends that, whoever is the significant others for these individuals need help too. So keep doing what you're doing, because I've listened to all your podcasts. I'm like,
oh, thank you.
These are great. People listen.
Well, for more information about burn prevention and information about the American Burn Association, you can go to their website at ameriburn.org. And for information or to apply for benefits, please go to ctpaidleave.org. This has been another edition of the Paid Leave Podcast. Please like and subscribe so you'll be notified about new podcasts that become available. Connecticut Paid Leave is a public act with a personal purpose. I'm Nancy Barrow, and thanks for listening.